So the question says, baby Kayuma, aged 3 days old, is admitted to the children's ward with diagnosis of neonatal jaundice. Besides other orders, the doctor orders phototherapy and exchange transfusion for baby Kayuma. Question A, define neonatal jaundice. Then question B, state 2 types of neonatal jaundice. Question C, explain 5 causes of neonatal jaundice. Then D, state 5 signs and symptoms of neonatal jaundice. And the last question is describe the medical management and nursing care of baby Kayuma during hospitalization. So we'll go straight to look at the definition. So when defining neonatal jaundice, we can define it as this is a neonatal condition affecting the endocrine system in which there is yellowish discoloration of the skin and mucous membranes due to increased levels of bilirubin in the blood, characterized by dark urine, lethargy, and of course clear white stool. So basically when we talk about jaundice, this particular condition can affect anyone including adults. The definition is projected actually. So the definition is projected. Yes. So when we talk about neonatal jaundice, I was saying this particular condition can affect even adults. However, in children, we see it commonly because of the state of the child. Sometimes it could be physiologically caused, sometimes it could be pathologically caused. And we see jaundice very common in children being seen. Now, the basic line for jaundice is that the body or the blood is having too much bilirubin. And bilirubin is not supposed to be found in the blood because bilirubin is an end product of broken down red blood cells, which is supposed to be excreted either through urine or through feces. But at a point where bilirubin can't be removed out of the body, then we see yellowish discoloration of the skin or the mucous membranes like the ones in the mouth and of those of the eyes. And also one of the characteristics we tend to see is dark urine. This is because when bilirubin is broken down, after it is conjugated by the liver, it needs to be reduced to urobilinogen. And urobilinogen is excreted through urine, and it gives urine that normal greenish color that we need to see. Because the normal color of urine, it should be amber-like, which is greenish and not yellowish concentrated, meaning that there's a problem with the liver. And without that urobilinogen, the color of urine that we'll end up seeing is darky urine. Apart from that, lethargy. Lethargy means that there is too much bilirubin that is also accumulating in the brain. And the child ends up looking like the child is very tired or weak. And that is what is usually described as the lethargy. Then apart from that, it is clear white stool. Again, when bilirubin is broken down by the body, the same bilirubin can be reduced to what is known as stecobilinogen. And stecobilinogen is what gives color to stool. But without stecobilinogen, it means that bilirubin is not being conjugated or being broken down further. And what we'll end up seeing is that the feces won't have the stecobilinogen, meaning that it will look clear white. But the normal color of stool, again, what we are supposed to get or to see, it is stool that looks a bit greenish yellowish, but greenish content or texture. Then we know to say the liver is working well. But in jaundice, we don't see that. So basically, this is how we can define jaundice. Now, when you look at the question, in the last exam, the last year exam, one of the exam where the pass rate was 9%, the people failed to explain the pathogenesis of jaundice. It's not part of this question, but when you go to the notes, it is well summarized, and I'm just going to explain it because we are talking about the pathophysiology. So I'll explain it so that as you read about it, or as you read the notes, you understand what it is. Now, the question talked about explaining how bilirubin is produced, and it is all coming from this definition. When we talk about bilirubin production, bilirubin comes from as an end product of broken down red blood cells. So when red blood cells are broken down, three things are produced. The first component that will be produced is the heme component, and the heme, which is HEM, and also the globin and iron. So when a red blood cell is broken down, those three components are produced. Now, iron is stored by the body and used for formation of new red blood cells. Then when we talk about the globin is converted to amino acid, and the body uses this globin to produce more proteins. But when you look at heme, the heme component, it is what the body converts to biliverdin. Then from there, it converts it to unconjugated bilirubin. Now, unconjugated bilirubin is fat soluble, meaning that it is a fat in nature, and fats and water cannot mix, meaning that the only way for the body to excrete unconjugated bilirubin is to conjugate it. In other words, making it water soluble. So in this case now, bilirubin will be transported from the reticuloendothelial systems, meaning where red blood cells are broken down. In this particular case, the spleen is the major player for breaking down dying red blood cells. So the red blood cells, the unconjugated bilirubin will be transported from these reticuloendothelial systems to the liver by attaching it to albumin. Remember, water and fats cannot mix, but proteins and fats can mix. This is the reason why unconjugated bilirubin is attached to albumin, because 60% of our body is made up of water, but it is not H2O, it is plasma proteins. So that is why it is attached to albumin, because it is a protein type of plasma protein. So once it is attached to albumin, it is now transported to the liver for conjugation. And in the liver, by the action of the liver enzyme, which is the glucuronidase enzyme, it is going to conjugate bilirubin. Once the bilirubin is conjugated, it will now be released in the biliary tree. And once it is released in the biliary tree, through the action of the normal flora in the intestines, bilirubin is further reduced to stecobilinogen or urobilinogen. Remember, in the intestines, we have the normal flora, which is the E. coli. So with the action of the E. coli, the conjugated bilirubin is further reduced to urobilinogen and stecobilinogen. So urobilinogen will be reabsorbed back into the blood and excreted through urine, and it gives color to urine, while stecobilinogen is excreted through feces and gives color to feces. So as you read through in the notes, the progression of formation of bilirubin is simplified. That is what it means. I deliberately got a question without that component so that people can also read the notes, and not only the notes, the summarized notes, because you end up leaving out certain things from the many notes. So basically that is about conjugation of bilirubin. Now we move on to our question. So we have defined what neonatal jaundice is. We can look at question 2. And question 2 was saying, state 2 types of neonatal jaundice. So the main 2 types of neonatal jaundice, of course, that we have the physiological jaundice and we have the pathological jaundice. Now, when we talk about physiological jaundice Physiological jaundice, this is a normal harmless condition seen in most newborn after the first 24 hours of life. And the main cause of this is due to immature liver function and increased red blood cell breakdown. So physiological jaundice is the normal process. The first thing that you need to understand is that when the baby is in the mother's womb, the baby needs around 2 liters of blood. Now, when the baby is born, the baby's body only needs half of that blood, meaning about a liter. Meaning that in the first few days of life, the baby's body has to break down these excess red blood cells. And now the body is breaking down this excess RBCs at a very faster pace, but this is a newborn baby whose liver is functioning for the first time. Meaning that the liver, it will not handle that pressure compared to the breakdown and processing of the unconjugated bilirubin. At the end of the day, we end up seeing this physiological jaundice developing in a newborn baby because the liver is failing to handle the pressure of the breakdown of RBCs. As a result, physiological jaundice will clear on its own, mostly even without any major interventions, because by day number 7, the baby's body or liver would have grown bigger to adjust. And by the end of the week, this particular physiological jaundice would have cleared. So that is how come physiological jaundice occur in newborn babies. Sometimes it could be the liver of the baby is handling the pressure well. However, newborn babies don't have the normal flora in the intestines. This is the reason why we see babies having stomach aches in the first few months or weeks of life, because there is no normal flora, and it is making it difficult for things to even be absorbed because even the villi is not very active. So again, with physiological jaundice, the baby may lack the normal flora. And that is the reason why we advise mothers to breastfeed the baby frequently, because we believe that this normal flora is delivered to the GIT through breastfeeding. And in physiological jaundice, you will see that intervention being done, because sometimes it is just lack of normal flora. So when we talk about physiological jaundice, that is how it usually occurs. But the other type of jaundice is pathological jaundice. And now with pathological jaundice, this type of jaundice occurs within the first 24 hours of life. And it is mainly associated with high bilirubin levels and rapid rise, of course, in bilirubin and prolonged jaundice. And this one indicates an underlying medical condition, which could be infections, hemolysis, or blood group incompatibility. So when we talk of pathological jaundice, this one, it will occur very fast within a shortest period of time, within the first 24 hours of life. And this only indicates that there is a problem that has caused this physiological jaundice. And mostly in physiological jaundice, sometimes the cause can be infections. Now, when we talk of infections, it could be sepsis. This will cause an increase in breakdown of red blood cells, and this can easily cause pathological jaundice. Sometimes it could be other factors where maybe the baby is lacking the glucuronidase enzyme in the liver, meaning that this is a pathological cause because there's something the baby is lacking which can facilitate conjugation. Apart from that, it could be also other diseases, hemolytic diseases like sickle cell. Now, in sickle cell, remember, the red blood cell is supposed to be oval-shaped, meaning that one red blood cell, we say it has 4 hemoglobins like that. Now, because a red blood cell has 4 hemoglobin, it is what gives it this particular shape. Now, in sickled red blood cells, remember that we say sickle cell, there is homozygous presence of hemoglobin S, meaning that on one hemoglobin, there is 2 hemoglobin S, and this changes the structure of the red blood cell. So in this particular case, the red blood cell becomes sickled like that. becomes sickled because the one red blood cell twists the HB to the other side. And how does this occur? Think of it, if this is hemoglobin 4 hemoglobin, meaning this is a positive sign, this is a positive sign, this is a positive sign, this is a positive sign. But presence of hemoglobin S changes this structure here, meaning that instead of this having a positive sign, maybe it will have a negative sign, meaning that this particular hemoglobin here ends up having mostly a negative sign. Meaning that if it has a negative sign, this opposite hemoglobin will be twisted to the other side. And this is what ends up giving us a sickled red blood cell. Now, a sickled red blood cell means that it cannot carry 4 hemoglobins, but it carries 2 viable hemoglobins. Meaning that it is now carrying half the amount of oxygen. So when the body realizes that the red blood cells are sickled and they are carrying half the amount of oxygen, those sickled red blood cells are broken down faster because the body is trying to remove them. They are not performing a normal function. And the end result that we end up having is now jaundice. That's why you see jaundice being common in sickle cell patients. But in this particular case, this child has sickle cell, meaning that they have a pathological jaundice because the cause is a medical problem. So that is how we end up seeing hemolytic diseases like sickle cell causing pathological jaundice. Amongst others, like blood group incompatibility. When we talk of blood group incompatibility, we talk of examples like ABO incompatibility, also rhesus factor incompatibility. In ABO incompatibility, this is where the mother is blood group O, but the baby they have is either blood group A, blood group B, or blood group AB. Now, remember that the mother, a person who has blood group O, is carrying antigens of both blood group A and blood group B. That is why blood group O is a universal donor. So in an instance that the baby, for example, is blood group A, it means that the mother already has antigens that can attack the antibodies of blood group A or blood group B or blood group AB. So when there is maternal fetal circulation and the mother's blood mixes with the baby's blood, immediately the mother's blood will easily start breaking down the baby's blood because that is still fetal blood. And because the mother has antigens of A, that is why we end up seeing that ABO incompatibility, meaning that the baby's blood will be broken down because of the antigens of the mother coming from the shell of blood group O. And that is where we see these blood group incompatibilities. Also, rhesus is the same. You expect the mother at least to be rhesus positive. When you check your blood type, you'll be told you are blood type A plus, or blood type B plus, or blood type O plus. That plus indicates the rhesus factor, not that you are HIV positive. So that is what we see in majority of our blood types. But in a case, some few individuals are born with the negative rhesus, meaning such individuals, when you are marrying someone, you have to marry someone who also has a negative protein. But when you find your rib and your rib has a positive protein, in science you have found the wrong rib. If we go back to the Bible, we'll advise you that you need to look for another rib, because the two of you will have difficulties having a child that will survive. And in an instance that you have your first child, the mother's blood becomes sensitized, meaning she will be having miscarriages for the subsequent pregnancies. Meaning that if this woman loses the first child, it will be impossible for her to have a second or other children. Or if this woman had an abortion before, they will have difficulties having a first child. So that is why in our Zambian laws, you find that those of you who have married through the church or planning to marry through the church, it is by law that you have to do these tests. And if none of them are not compatible with your partner, the government has to advise you to find a new rib. Even your pastor will advise you to find a new rib. because that rib is not compatible. No matter how much you force yourself, at the end of the day, your marriage will break because there are no fruits coming out. So again, rhesus factor incompatibility is another hemolytic cause, or I mean blood group incompatibility, which is a pathological cause. So there are a number of causes that you will read through in the notes that results in pathological jaundice. But however, these are the two forms of jaundice that we can talk about. Unless there's a question before we move on. Okay, so the next question is talking about the causes of neonatal jaundice, and I think I've even explained this, like ABL compatibility and the others. So for your explanation, those who didn't get my explanation, at least they are here, the answers are here. So ABL compatibility results in increased hemolysis of red blood cells, which increases bilirubin levels, and this causes jaundice. So mostly when you're doing ABL incompatibility, you do genetic testing. When we tell you that you need to do these tests, which includes HIV, there are a number of tests when you're marrying that are done at the local council. So when we tell you to do those, we will ask you to do high-level tests, not just the ones that are done on our clinics or level 1 hospitals. At least you need to do genetic tests so that we check your ABO type and whether there are chances of having ABO incompatibility, so that you're advised accordingly. So ABO is one of the causes. Rhesus incompatibility, I've talked about it. For this one, of course, like in Lusaka, we have the fertility clinic. You can be given a drug to prevent rhesus sensitization in the first 72 hours before you deliver, so that you have a chance of having a second child. But even with that treatment, you may have difficulties having the second child. Maybe it may even take 10 years later for you to just be able to have a second child that will survive, because within the first 5 years it's almost difficult, unless with proper care, even with treatment, or to prevent that interaction of rhesus. So rhesus incompatibility is another factor, meaning that we need to know our blood type, so that in an instance where we have aborted before, or we are pregnant, even if that man refuses, I know men, we are good at running, just keep that child, because you know that if I abort, I will never have another one. So even if the man runs away, refuses a responsibility, at least would have had the first child. So rhesus incompatibility can cause increased hemolysis of red blood cells, hence leading to jaundice. And the explanation is also there. But all you need to write is just this first statement and the last statement highlighted. This whole information here is just for your explanation. The other cause is sepsis. When we talk of sepsis, this increases breakdown of red blood cells, and this can increase the levels of bilirubin, hence resulting into jaundice. Apart from that, sickle cell disease, we are going to look at sickle cell in medicine. Should be, I think, next week. We'll look at sickle cell. And in sickle cell, like I mentioned, the red blood cell is sickle shaped, and the body reduces the lifespan of a sickled red blood cell from 120 days to less than 30 days. Meaning that this person will have red blood cells being broken down almost every day. And this is almost the entire system being broken down. So this is why we end up seeing jaundice in sickle cell, because the lifespan is reduced because of the sickled red blood cells. And this increases the levels of bilirubin, causing jaundice. But we'll talk about sickle cell in details. Apart from that, biliary tree obstruction. Now, the other question that is accompanied with jaundice is you drawing the biliary tree. When you go to the notes of the diagrams that I sent, you find the biliary tree that looks like this. So that is why when you draw in the exam, when we ask for drawing, we expect you to draw a nice diagram. Because for me who marks these courses, I can draw this. Then you who is writing an exam, why should you fail to draw? So we expect you to draw these diagrams nicely for you to even be given marks. So when we say the biliary tree, it looks like this. You have the pancreas, this is the pancreas, you have the liver here, you have the gallbladder here, you have the intestine there. This is the common bile duct, we have the pancreatic duct here, and we have the duct joining from the gallbladder. So when we say biliary tree obstruction, it means that any portion of this biliary tree is blocked, and the conjugated bilirubin coming from the liver can't be excreted in feces. So biliary tree obstruction is obstruction at any portion of this particular common bile duct. So this will prevent breakdown of conjugated bilirubin to stechobilinogen or urobilinogen, meaning that the end product is that this conjugated bilirubin will be in the blood, and this will result into jaundice. So that is how biliary tree obstruction is one of the causes of jaundice. The other cause is, of course, liver immaturity. And liver immaturity, especially in newborn babies, they may not have the liver enzyme, the glucuronidase enzyme, to conjugate bilirubin. And this can result in accumulation of unconjugated bilirubin, leading to physiological jaundice. So those are some of the causes that we can mention. There are many causes, including malaria, and we are going to look at malaria very soon. So all these topics we are going to look at. We can move on. Says, state 5 signs and symptoms of neonatal jaundice. So when we look at the signs and symptoms of neonatal jaundice, the first one is, of course, poor feeding. And poor feeding is due to excess of bilirubin in the blood, resulting in lethargy. Then, of course, dark urine. This is due to inadequate reabsorption of bilirubin from the gastrointestinal tract, causing lack of stechobilinogen. Of course, the other symptom is enlarged spleen. Enlarged spleen, this is due to accumulation of blood in the spleen. Then, of course, yellow umbilical cord. This is due to increased bilirubin in the blood. Other symptoms includes yellow discoloration of the skin and conjunctiva. This is due to increased or excess levels of bilirubin in the blood. Lethargy, this is due to irritation of the nerve ganglion, and this causes the child to be lethargic. In an adult, lethargy is what we call fatigue, but in a child we call it lethargy because the child can't say anything, you can't see it because there's no activeness. So all you will see is that this child looks like they are just sleeping, they can't wake up. Even when they are they wake up, they look very weak. So you interpret it as lethargy. This is just due to irritation of the nerve ganglion. And of course, dark urine. This is due to inadequate reabsorption of bilirubin from the GIT, and this causes lack of urobilinogen. So when we talk of some common signs and symptoms, these are some. The question requested for 5, and you can write any 5. Okay, so that is about the symptoms. The last question was talking about management. Now, when we talk of management for neonatal jaundice, sometimes they may just ask you to write the nursing management. Sometimes they may ask you to write both the nursing and medical management, and sometimes it is nursing care plan. So those are the three common managements that come in jaundice. But every time a question for jaundice comes, a question for IMCI comes, a question for what? For malnutrition comes, there is always a high failure rate. So we need to read these three. In the recent past, the condition infectious diseases questions have come. We have seen questions for other conditions also coming, or infectious diseases coming. So you need to know these three because they are different from the rest: malnutrition, IMCI, and of course jaundice. IMCI, we had it last year. There was a 10% pass rate, so you just have to know them even if they are difficult. So in terms of management, you start with aims. You can talk about to identify the cause of jaundice. The other aim you can say to promote a quick recovery. You can talk about promoting excretion of bilirubin and to prevent complications such as kernicterus. So kernicterus is where the baby collapses, goes into unconscious state because of high levels of bilirubin in the brain. Then of course, the question said medical and nursing management. In terms of the investigations that we can do, of course, you can talk about history taking. And history taking, you can talk about either contamination during delivery or history of conditions like sickle cell. So contamination of delivery, meaning that there is sepsis. So you can pick any risk factor as a history taking point. Then during physical examination, the child will have yellowish discoloration of the skin and mucous membranes. You can do a Chum's test, and a Chum's test will detect antibodies for ABO or R rhesus incompatibility. So for a Chum's test, you are getting blood directly from the umbilical vein. Then you do the Chum's test. That will show whether it is ABO incompatibility or rhesus incompatibility being caused in a newborn baby. You can also do liver function test. It will show low liver enzyme. Apart from that, you can do a full blood count, and in a full blood count you will see raised white blood cells, especially if it is sepsis that is causing it. You can also get blood for serum bilirubin level, and it will be elevated. So these are some of the investigations that we can do. Once you talk about at least 5 investigations, then you can talk about the treatment. In terms of treatment, this question has not specified the type of jaundice that the baby has. So if the question has specified that maybe the cause is malaria or the cause is sepsis, it means that on treatment, you need to mention antibiotics or antimalarial drugs. But in this case, our scenario has not mentioned any cause whatsoever. It means that on treatment, you're giving general drugs that are given no matter the cause of jaundice. So in this case, we can give anti-D globulin. This is given to the rhesus negative mother within 72 hours of delivery, and the dosage is 300 micrograms intramuscular, and the mode of action is that it destroys any fetal rhesus positive red blood cells before the mother's immune system is sensitized. So this anti-D is usually given to prevent this mother from to promote the mother so that they can have another child after the first child. That is the more reason why it is given. It has common side effects such as pain on the injection site and rash, and of course administer within the first 72 hours to prevent hemolysis. The other drug that we can give to the child is phenobarbital, And phenobarbital, this one reduces faster the levels of bilirubin in the child. And the mode of action, this one is a barbiturate drug. And barbiturates, they work by blocking the GABA receptors in the brain, and this reduces the brain activity. Phenobarbital has side effects like sedation and respiratory depression, meaning that we need to monitor the respiratory rate for the baby to prevent respiratory depression. We can also give amoxil 125 milligrams per 5 meals, meaning this is a suspension drug, 3 times a day oral to prevent infections, because infections they may worsen jaundice. Apart from that, we can give an anti-inflammatory drug as well, like hydrocortisone. In a child, you give the lowest dose of 25 milligrams. 25 milligrams, of course, you give the intramuscular one, and it is just once per day for 5 days. It is a corticosteroid drug, and hydrocortisone will just also promote maturation of the liver. At the same time, it also improves excretion of bilirubin. So in a scenario like the one we have, where they have not specified the cause, these are the drugs that you can mention under medical management. But if the question had specified, like some scenarios, they will specify for you that the child maybe has history of or has malaria, a malaria test has come out positive, or the child has sepsis, meaning in that case, on medical management, specify the drugs that you are also giving, either antibiotics, or you are giving antimalarial drugs if there is a known cause. So once you mention the medical management, then you are ready to go to the nursing management. Now, the nursing management, we are not using a prophenema or the other outlines that we have looked at. For jaundice, whether the cause is pathological or the cause is physiological, the heading for management during phototherapy is always the first heading. You always talk about it. Whether pathological or physiological, phototherapy treatment will still be used. So the first heading will be management during phototherapy. And the first point here, you can say, I'll nurse the child under phototherapy machine to change the shape and structure of bilirubin so that it is easily excreted. The other point, you can say, I'll place the baby 50 centimeters below the phototherapy machine to prevent burns. You can also talk about nursing the baby completely undressed to expose the entire skin to light to promote excretion of bilirubin. Apart from that, another heading under the same management during phototherapy is eye care. And on eye care, you talk about covering the child's eye with an eye pad with that padding to prevent retinal detachment. You can also talk about performing eye care to promote moisturing of the eyes. In OSCE, there is a procedure known as eye care. It's a sterile procedure. These are small procedures that will make you fail the exam. In your exam in June, you only have maybe 2 sterile procedures or so. The rest will be clean procedures. So if you just say, no, I'll just go through sterile procedures, then for OSCE, forget about it, because you won't clear. So you need to read more of the clean procedures. They are the ones that will make you pass. Whether you are preparing for your midwifery or general, you need a lot of clean to go through those clean procedures. They are the ones that will make you pass the exam. Skin care, you talk about cleaning the skin with warm water to promote moisture of the skin and prevent skin dryness. You can talk about turning the baby too early to prevent burns of the skin. The other heading is genital care. You can talk about covering the genital area while nursing the baby under phototherapy machine to prevent infertility. So genital care, you do both. You cover the baby girl, also the baby boy. This is because babies, when they are born, they have a functional genital area, or the reproductive system is functional. That is why by the end of 1 year or 2 years, you will see these traits rather in a baby. If the baby is a baby girl, they will be attracted to the father or any male person. If the baby is the baby boy, they will be attracted to the mother. It is because at birth, both sexes, they have a functional system. But when you see those traits, you should be happy as a mother. And you need to make sure that the baby is held by the opposite sex. Because if you prevent that mechanism, in psychology, these are the homosexuals that we end up having, because the baby was not exposed to that, and that area never developed fully. It was never satisfied. So let the baby be held by the opposite sex at that phase. Let them enjoy that phase. It's normal for growth. So the genital area should be covered to prevent damage either to the eggs that the baby is born with, or to the testes, even though they become functional at puberty. The next heading is promotion of hydration. Here you encourage the mother to breastfeed the baby to promote hydration. You can give normal saline 5 ml per kg body weight to prevent dehydration. This can be caused because of phototherapy treatment. From there, you talk about observations. Observations, of course, talk about observing the vitals. You explain why you're checking the temperature. You can check the skin color in order to detect improvement in the condition. You can monitor signs and symptoms of dehydration, and this can trigger increase of fluid intake. So from there now, the next heading, these ones are common, and the points are the same that we have looked at from prematurity, the other conditions that we did. Prematurity, we have not yet looked at it, but asphyxia, RDS, and other neonatal conditions we have done so far. The headings are the same. Psychological care, you talk about explaining the condition to the mother to promote knowledge. Let the mother ask questions, allow the mother to be involved in the care of the baby. All those points are found on psychological care to the mother. Hygiene, talk about performing top and tail. In a newborn baby, we don't talk about baby bath. You only talk about top and tail to promote hygiene. That's why I'm saying you need to go, those of you who missed RDS or asphyxia, go to that management, because when we do prematurity, we already looked at both the nursing care plan in details and the management in details. So we won't go in details, we'll just show you the outline. But these points, you can get them from the condition we did for prematurity, rather for RDS or asphyxia. Hygiene, top and tail, changing of nappies, all those points. Nutrition, you just talk about breastfeeding, no any other foods. Medication, ensure that the child is receiving all the prescribed medication. Explain the side effects to the mother and the importance of giving the child the drugs. Elimination, of course, observe urine output, and for color and amount to monitor the recovery process. Also observe bowel opening for color of stool to also monitor the recovery process. Advice on discharge, the advice is the same. You can give advice to the mother on the importance of keeping the baby warm, importance of preventing infections to prevent conditions like jaundice, importance of immunization, so that the child can be protected against common infectious diseases. Also hygiene, code care, all those are common points that we put in pediatrics under advice on discharge. So basically this is the management outline. If you are asked for medical and nursing management, this is the outline. But in a case where you're asked for the nursing care plan, there is a red point here to say it's a self-assessment. Complete the following nursing problems at your free time. So I have at least given you the nursing diagnosis, and these conditions we have done them several times. So all you need is that as you study, try to finish up the other areas like the one for interventions and the evaluation. So the first problem we can talk about is impaired tissue perfusion. This is related to increased bilirubin level in the blood evidenced by pallor and cyanosis. Then of course we have impaired skin integrity. This is related to increased levels of bilirubin in the blood evidenced by yellowing and breakage of the skin. The other problem we see is impaired nutritional status related to impaired feeding as a result of lethargy and evidenced by weight loss or small for debt. The other problems we can see is risk for infection related to lowered immune system, because when the baby is born, their immune system is always low. Our immunity is always strong or fully strong after the age of 21. Hence, we talk about risk for infection. Risk for fluid volume deficit related to impaired feeding as a result of lethargy. So when we talk about the nursing care plan problems, these are the problems we can use. Most of the time a nursing care plan, they just change from nursing management to nursing care plan. Sometimes you find that it may be this same scenario you have looked at, but then it is just the difference in the management. So we need to look at both as we study, especially for jaundice, because people fail to write the nursing care plan. And when marking nursing care plan, those of you who missed, we start by marking the diagnosis. If your nursing diagnosis is wrong, you have lost the entire 10 marks for that problem. We can't mark the other areas no matter how correct they are, because your nursing diagnosis is wrong. So you need to make sure that your nursing diagnosis is correct for the other areas of the care plan to be marked. So before I end the session, because this was our last slide,